And that this is the one they're looking for. This is that makes them feel good. I had one guy that had liver cancer so bad that he was going to die anyway, but he kept telling his wife that he needed to get this strain because this one made him feel better, took his pain away while he was dying of liver cancer. And I cried with him up there about it, and he told me, it's the nicest thing anyone ever said to me. Before he died, he said, when I get up there, I'm going to tell Jesus about you. And that really meant a lot to me. That really meant a lot to me.
My name's Winslow Engel. I'm an internist and a physician who runs a pain program in HAWAII. I really want to speak from my profession and speak to the community of patients and potential patients out there. You know, we really are in the midst of a revolution, but I don't know, not like the Revolutionary War that we learned about in school. It seems like this revolution has been coming for a long, long time, and it's been evolving, and certainly my relationship with the changes that we're talking about here have been small steps, really incremental steps. And I think it's instructive and helpful, hopefully it is, to take everybody through that process a little bit. I started working with chronic pain patients not because it was a part of my training, but because I have had an interest in working with underserved populations throughout my career. And about 20 years ago, I moved to rural South Carolina in an underserved area. And I'd been there about 2 weeks when the only doctor in town who was treating chronic pain passed away suddenly. And they all were knocking on my door. And it was a moment that I really had no preparation for, but I'm building a practice, you know, so it was expedient, it was necessary. And right now, in Hawaii, we have a lot of practitioners who are eyeing this situation and hesitant, fearful, but guess what? The opportunity, not just to profit, but really the opportunity to maximize the service that we provide to our patients is going to compel physicians to move with the times and accept this new, I won't even say challenge, this new, really wonderful opportunity to make a difference. I came here from Washington State about 5 years ago. I had a few medical marijuana patients in Washington State. I moved to Hawaii, and 50% of my time is with chronic pain patients. And the story that I heard over and over again, almost as if people were reading from the same script, was, Doc, you know, I have terrible pain. It's a huge problem. But when I go to physicians, all they seem to want to do is either prescribe opioids or send me to somebody who's going to prescribe opioids. And I've tried them all. And I don't like how I feel. They make me sick. They make me tired. And if I smoke, it helps the pain. And the side effects are that I feel energized. I sleep better. My appetite's improved. My overall sense of well-being is enhanced. I mean, you can't hear that story over and over again without accepting it as basically a moral imperative. But again, I was kind of incremental. The first thing I did in my pain management program, where we, you know, aggressively do urine testing on our patients, the first thing I said was, we're not going to test for THC. It doesn't make any sense. I mean, what do we do when somebody screens positive? I'm not going to reprimand them, maybe I'm going to take the ones that screen negative and say, you ought to possibly consider this, you know. So early on, it was like, no, you know, we're going to test for cocaine, we're going to test for methamphetamine, which is a huge scourge on the West Side. We're not going to test for marijuana. But then I started asking the question, well, you know, we have a medical marijuana law. Why do we send our patients across the island, you know, paying out of pocket? And I have nothing against physicians who charge for that, but Waianae's different, you know, and our community, they're challenged often, and they're not going to make that trip. Well, I asked my colleagues, and everybody said, well, we're a federally qualified health center, and we receive a lot of federal dollars, and the federal laws being the way they are, you know, we don't want to raise that awareness of what's going on. So I asked for an opinion from counsel. By the way, I'm so comforted to share the podium with you know, an attorney who I just instinctively feel like he's on my side. It's really, really nice, really different. But I asked the clinic counsel to weigh in on the issue, and their answer was, there's no problem here. Because basically the role of the physician is diagnostic. It's to determine if this individual has a qualifying condition. So with that information, I said, well, yeah, I guess so, it's time, you know. And so that's kind of why, like, you know, myself as a super busy physician with you know, 25, 30 complicated West Side patients on my schedule every day, it still makes sense to squeeze, you know, 2 or 3 patients into my schedule because they want their card. And the other compelling reason is 44 people dying in the United States every day from overdose of prescription painkillers. That's 16,000 people a year. It's roughly the number of US soldiers that have died in the war in Afghanistan during all the many years that that's been going on. But this is 1 year in the United States. And just like the tragedy of soldiers being killed, that is also just the tip of the iceberg. You know, when you work with patients on opioids, keep your eye open. If you start reading the literature, you realize that the consequences of chronic opioid treatment, especially high doses, and University of Washington has done really elegant research into this, and the conclusions are incontrovertible, that the effects are much more than what we want to acknowledge. That chronic high-dose opioid therapy does not just cause constipation, you know. It causes cognitive changes, it causes mood changes, it causes changes in sex drive, it messes up the entire neurohormonal system, you know, the connection between the brain and the glands in a person's body. These really are life-destroying and often relationship-destroying drugs. And I can tell you that when I have a patient who comes in and says, Doc, I want my card, and I will give up the option of taking narcotics in order to have that, it's a huge victory. It's a huge win. Those are the kinds of moments that as a physician I live for, you know. Again, I gravitate towards underserved populations. It's not because I'm super altruistic. I like underserved populations because I can make a difference there. And guess what? I also get a certain level of appreciation that I wouldn't get with patients from a different setting. we have a lot of challenges. There's still, I think, a small minority of the potential patients in Hawaii have their card. That number should grow. It can't overwhelm poor Department of Health. You know, I really feel bad for them. Thank you. They have their challenges, and it can't overwhelm the distribution system. But percentage-wise, the 14,000 or whatever that we're talking about, they represent, what, less than 1% of the population of Hawaii? I'm sure that 5% of the population of Hawaii has a qualifying condition, so we have a long way to go. We have to convince physicians to get on board. And you, the patients and potential patients out there, I think really are in a pivotal position to influence this. You know, I think it's incumbent on you to make it clear to your doctors that you want their help, you know, that you're disappointed if their response is, well, go see Dr. So-and-so and pay $250. After all, who knows you better? Who better to assist you? Who better to make judgments about what is in your medical interest than your PCP? I have questions myself, and questions I'd love to discuss with attorneys and others about kind of the limits of what I can do. You know, right now I don't, quote, prescribe. You know, I determine that somebody has a qualifying condition. I take them through the process. I make a judgment about risk versus benefit, but I'm not trained, and I'm not quite ready to say, this is the strain that, you know, you have fibromyalgia, you should be looking at this, or maybe you should start the day with this and then transition to this later in the day. You know, I want to get that expertise, and I want to feel the freedom and the legal protection to get involved with my patients at that level. I also want to be able to talk about routes of administration. I have patients with asthma and chronic obstructive pulmonary disease. They really shouldn't be taking a lot of particulates in through their lungs. A couple of things I want to say in conclusion. One is, let's just go back to the World Health Organization definition of health. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, if you think about that from the perspective of a physician, how many opportunities do you think we really have to recommend a change in a person's treatment that will affect their complete physical, mental, and social well-being? It's a rare opportunity, and that's one of the reasons that this is a very special change and a tremendously gratifying transition that we're experiencing in the medical profession. And the last thing I want to do again is to empower everybody out there who is a patient or is a potential patient. Remember, I'll just list the qualifying conditions again: cancer, glaucoma, HIV/AIDS, cachexia, which is severe weight loss, severe pain, severe nausea, seizures, and severe or persistent muscle spasms, including those characteristic of multiple sclerosis or Crohn's disease. That's a lot of people. Thank you. Thank you. I wasn't aware of that. Thank you. I'm glad to know that. And that's huge. And again, a little bit of a link between with the analogy I was trying to draw between the consequences of warfare and the consequences of the war on drugs in the United States. You know, but that's fabulous and long overdue. Thank you very much.